take a stop, repeat something, answer questions, feel free to raise your hand. I'm happy to answer questions or repeat. Okay, so cancer pain. So moderate to severe pain occurs in approximately 50% of patients who are receiving active treatment for their cancer, and 80 to 90% of patients with advanced cancer are experiencing moderate to severe pain. Okay? Undertreatment of cancer pain is super common. There's needless suffering that happens. It's difficult, increases their quality of life. It's difficult on their caregivers. So we have to consider when these cancer patients tell us what their pain is, we have to believe them, right? We have to believe them. Sometimes these patients don't want to tell you their pain level. They may have heard, there may be, we'll talk about various reasons why they may not report their pain, okay? So be aware that those are there, and we're going to talk about that. They may require higher doses of pain medication because they are in chronic pain, okay? So you might be having to give lots of morphine IV to these patients, really high doses, and you may feel a little concerned about that. A lot of these oncologists have followed these patients for a really long time, so they know how much they need. So just be aware that that's it, okay? Of course, we don't want to expect that they're going to be playing the system. We want to take their word for what they say it is, okay? So pain is subjective. There's physical, there's emotional components linked to it. And we've spoken previously about how a person's pain reaction is going to vary upon their previous experiences with pain. Their age, culture, all kinds of considerations go into that, okay? Acute pain occurs suddenly and it's short term. It could be caused by surgery, something like that. Chronic pain results from nerve changes, and this pain is going to last for longer than 3 months. So this can be caused by tumor growth. So the tumor is growing, it's affecting the tissue around it, it's causing destruction by pressure, and that can cause that chronic cancer pain. So let's talk about some indicators of acute pain. So some nonverbal indicators. Can anybody think of some nonverbal indicators that might lead us to believe our patient is in acute pain? Grimacing, agitation, they're irritated. What about, say it louder. Restlessness. How about what might you see with their blood pressure, their heart rate?
Pressure elevated.
Right, they could be tachypnic, right? They may be sweating, pupil dilation, they might splint the area. Okay, so those are some indicators that these patients might be in acute pain. What are some nonverbal indicators of chronic pain? So long-term, over 3 months pain. Exhaustion, yeah, they're not sleeping well. What else? Think about mental health. What would that do to them?
Depression.
Might see depression, angry, yep, very good. Be weak, lethargic. So these are some symptoms we might observe in our patients. So different types of pain. Neuropathic, nerve damage, caused by nerve damage. Patients might experience numbness, tingling, burning, radiating pain. Visceral or deep pain, that's going to be inside the internal or in the internal organs. Kind of difficult to identify exactly where at. They may just be in a general region for these patients. Deep, sharp pain might be how they describe that. Somatic occurs in bones or connective tissues. Very localized, sharp, dull, throbbing pain. So the greatest barrier to effective pain management is inadequate pain assessment. Very, very, very true statement. As RNs, we're supposed to be asking our patients all about their pain, right? We're asking them the quality of their pain. What's it feel like, right? They're going to be telling us. There's a lot of myths that patients, especially cancer patients, believe about pain, and they don't get real answers, so we need to be aware of those, and I'll talk about those here in a second. We need to educate them on their pain medication, why they're taking it, when they're taking it, things like that. Assess their pain every single time we go in. Okay, asking them, are you comfortable enough? Ask them the intensity, the duration, describing, okay? Is there something the patient does to help relieve their pain, right? Whether that's medication or not. Maybe something in the past, maybe medication has worked for them, and we're not offering that to them because we didn't know it. And they tell us, hey, usually this is what helps me, okay? And they may think that we have the know-all, but they may have the intel that we need to get them out of pain, okay? So vital signs, not always is that going to be a reliable indicator of pain, right? Maybe the acute pain, but that chronic pain, when they live in that pain, it kind of their baseline goes down a little bit, right? That's kind of their baseline. Okay. So they may not behave like they're hurting, they may not speak to you like they're hurting, so be aware of that. So clarify misconceptions. A lot of patients are worried, I'm gonna get addicted to the medication, or I need more medication now, so I'm addicted to it, right? Is that addiction? What is that? Tolerance, right? They have a tolerance to it. A lot of patients, like I mentioned in our Kahoot, a lot of patients think that cancer pain is just unavoidable. There's nothing that we can do about it. I just have to live like this because these are the cards I was dealt. That's not true, okay? And we have to make that education point on these patients. Non-pharmacologic interventions, some people think these are hooey and some people think, that's not gonna work. It really is effective for a lot of these patients, or some of these patients. So encouraging them to seek out non-pharmacologic interventions, distraction, obviously heat and cold, that really does help a lot. Relaxation helps. And side effects. Some patients will choose not to take their medication simply because they get constipated all the time and they don't want to deal with it. My sister's father-in-law has been actively dying with cancer for, a year and a half, 2 years. It's been a really, really long road. He was very emaciated. He's still able to get up and around, but he is in immense pain all the time. Constant pain. It's really, really hard to see him. Looks like a completely different person, but he does not want to take his pain medication because he's worried about the constipation and he's worried about the nausea. And they tried it. He is a very hard-headed man, I will say that. But he doesn't want to. It's not something he wants to. So some education points of him, maybe trying to find some other means to manage his constipation would be helpful for him. But we need to educate our patients that you don't have to live like this. This isn't how it has to be. We have ways to help you. So pain management, we don't just talk about medication. We can use surgery, chemotherapy, radiation, as well as pain medication to help reduce the pain. So we may go in, we may reduce the tumor size because the size of that tumor is pressing on other organs, it's causing necrosis in other organs. And so we can alleviate some pressure and get them some help in. We can do the same with chemotherapy and radiation. We could just be using it to shrink the size of that tumor for palliative measures so that they feel better, so they're not in so much pain, okay? So the next slides, we're going to talk about different medications we can use for different types of pain. So we select our medication based on the character and the cause of the pain. So we've got to balance the analgesia and the side effects. We have to do that balancing act so that we can have optimal functional status, okay? So we'll talk about some NSAIDs. So for longer term pain, persistent longer term pain, we might be giving them NSAIDs for inflammation. So that'd be like ibuprofen, naproxen. Giving them opioids like hydrocodone, oxycodone. We may be giving them long-acting morphine. Fentanyl patches is something you'll see commonly with these patients. When we talk about adjuvant pain medications, we might be giving like antidepressants, anticonvulsants, steroids, topical agents. Those are all considered adjuvant pain medications. Corticosteroids, we talked about those. Those can be anti-inflammatory to help reduce cancer pain as well. So the pain might be so much that the physician wants to prescribe a nerve block for these patients or a local anesthetic. Some patients may have a pain pump that gives out like a basal dose. For short-term breakthrough pain, you guys know that breakthrough pain terminology, what that means? So these are going to be our PRN medications, so medications that are given as needed. So that would be like fast-acting opioids, like fast-acting morphine PO, or we can give IV medications to help control the pain. Once you have out of control pain, I think anybody who's ever had broken a bone, had a baby, had a surgery knows that once you let that pain get away from you, it's really hard to get it back under control. So some of these patients might be on timed medications, pain medications, to make sure that that remains under control and we don't let it get away from us. Okay? So in your ATI book, there is a list of medications. I want you to know the ones that I just spoke of, but in your ATI Med-Surg book, pages 646 through 648, you can see some nursing actions and some client education points for some of those drugs I just mentioned. I want you to just go take a gander at them. Just look at them for me. Just the ones I just mentioned, so you can have a good background on some of these pain medications. Because we don't just use these medications for cancer, right? We're using them all the time.
What page did you say?
646 through 648, and that's going to be your ATI Med-Surg book. We all know that uncontrolled pain is going to affect their immune system, it's going to affect their healing, it's going to affect their relationships, things like that. So we need to be on top of this, okay? Their ability to respond to surgery, chemotherapy, all of that can be inhibited by them being in pain, okay? All right, everybody good? Okay. Just for fun, because I like to. We'll do a Kahoot really quick. Okay, let's see what we know. Do you guys like the lights like this, or do you want them on? You like this? Okay. Did you guys have a chance to look over the cancer material from last week? Some of us did. Okay, so you guys get to be done with me lecturing for a couple of weeks after today, so, or a couple of sessions, I guess. Okay, you guys ready to start, or is anybody still trying to input? Are we ready? Okay, I'm starting. Okay, I'll let y'all read on it. Sorry, the picture just went up there. Leukemia. Good job. Leukemia is the answer. Whoever just typed in the
I know
code,
it.
you are
The smartest.
You're first. All right. Move the pin to the arm that cannot be used for blood pressures or injections. Have you guys seen a limb alert? A limb alert, that means we cannot use that particular limb. We'll talk about why shortly. A few of our other lectures right on their arm. Okay. Who's at the top? Mia. Second. talk about that here. Oh, that majority of you got it right. Sydney, good job. Alright. True, false. And remember, the quicker you answer, equal points. False, very good. Sydney's still at the top, Madeline moving up. True or false again? I don't know what the picture is. True. Sydney's still at the top. Maddie moved in. Good job. Not oral cancer. Leukemia often requires bone marrow transplant. Sydney stayed at the top. True, false. Double point. Don't know why. Everybody got it. Good job. Let's see who got the most points for. Sydney still top. It's pretty close there. 23 points. Which cancer is linked to HPV? It is oral cancer is the answer. And now that I'm looking at esophageal, maybe too. I didn't Alyssa in second. Sydney still at the top. Just a few more. This is a Whipple procedure. Grace Nasty. I'd rather try my nasty. Sydney, still up. True or false? Breast cancer does not only affect women. That's false. Breast cancer. I'm sorry, I'm stressing you out. No. Last one. Double points. Oh, God. We all know who the real winner is. Yeah. Breast cancer. We learned that in our last lecture. So let's see who won. Sydney, are you still at the top? Bryce, third place. Celeste, second. Sydney, still at the top. Can you cue for you? Okay. Good job. Thanks for participating. Okay. Answer time. Does everybody have this up ready? older version of it. The only difference is it's gonna have the date is different. I do go through them before every time I lecture and make sure that everything's up to date, make sure there's not anything I see that's outright, like spelling errors or things like that. But I didn't have to change anything. So if you downloaded it prior to it saying, if it said MP3 spring, it's still the same. Okay, different terms for different types of cancers. We have carcinomas. Those are cancers that are the skin or tissue that lines the entire internal organs. If you hear sarcoma, we're going to be talking about a bone cancer or a muscle fat connective tissue cancer. Leukemia in the bone marrow, we just talked about that a little bit. Lymphomas and myelomas are going to be the cells of the immune system. And then central nervous system in the brain and spinal cord, which we do not talk about any central nervous system cancers. These are the cancers that we are responsible for learning in MP3. And we are going to start off with leukemia. Okay, leukemia, we are not going to see a solid tumor because this is a cancer of blood cells, white blood cells specifically. Okay, so basically we have these white blood cells that are not functioning. They invade and destroy the bone marrow, and the bone marrow is where what is made. What's made the bone marrow?
Blood
Red blood cells. Our blood cells are made there. So if we have all these leukemic cells taking over, then we're not creating the blood cells that we need to create, right, to fight off infection and all of that. Okay, so that's basically how leukemia works. Okay. It follows this progressive course. Eventually, it's going to be fatal if we leave this untreated. But there's been a lot of progress in successful cancer treatments. It's been really, really rapid for the hematopoietic cancers and lymphoid cancers in the last 30 years, so we have some good treatments for it. Here is a good video you'll watch.
When most people hear the word cancer, they usually think of a tumor. So they think of a group of cells that are dividing really rapidly that eventually form a mass. And you can see that mass, you can point to it and say, that's a source of our problem. We need to get rid of it right away, either with surgery or with medicine. And I think what makes leukemia harder to understand and harder to visualize than other types of cancers is the fact that with leukemia, you don't necessarily see a tumor. And that's because leukemia is a cancer, it's a cancer of the blood. Specifically, it's a cancer of blood cells. So what are these cells, these blood cells that I'm talking about? Well, let's draw a blood vessel, which is where all of the blood is contained. And when most people think of blood, they think of a liquid. So that's what I'm shading in, the liquid part of the blood. But blood has lots of cells in it too. So for one, it has these cells called red blood cells, and hopefully you can see that, which are really important for carrying oxygen. And oxygen is required by all of the organs in our blood. Everything from your brain to your muscles require oxygen. And then there are these cells that are called platelets, which actually aren't cells at all. They're little chunks or fragments of cells that form blood clots to help stop bleeding. And then you have these guys. There are several different types of white blood cells, which is what our body uses to fight off infection. So these are the guys that protect us from bacteria and viruses and parasites. So these cells are found in the blood. That's why they're called blood cells. But they're actually not made in the blood. They're made inside the bone. So I'm going to draw a bone. And if you were to look at the bone, if you were to look inside the bone, so if you were to take a slice of bone like this and you were to look at it, so this is your eye right here looking inside the bone, you'd see something like this. You'd see that on the outside of the bone is this hard part that we all know about, but that you'd see that bone isn't solid all throughout. There's actually this hollow cavity in the center of the bone, and that hollow cavity is filled with this red spongy tissue. And that red spongy tissue is called bone marrow. And bone marrow is where all of these different blood cells are made. So I'm going to clear that out so that we can see what bone marrow looks like, what's going on inside bone marrow. So if you looked inside, you'd see red blood cells being made, you'd see some cells making platelets, and you'd see white blood cells being made, right? And this is normal, this is all completely normal. But in leukemia, one of these cells, it could be a red blood cell, a platelet, or a white blood cell, starts multiplying really rapidly and out of control. And it starts overtaking the bone marrow, kind of like this. And that's a problem for two reasons. Firstly, this cell that's dividing really rapidly, this leukemia cell, doesn't serve any function like a normal blood cell does. So it doesn't carry oxygen, it doesn't fight off infection or help make blood clots. It kind of does nothing. It's kind of a waste of space. And that's a problem because we don't want to use any of our body's energy making cells that don't help the body, right? And secondly, it's a problem because if any one cell starts dividing really rapidly and taking up a lot of space inside the bone marrow, that leaves behind very little space and very little food for the other cells to grow. So because of this, the bone marrow isn't able to make as many of those other normal healthy blood cells. And if it can't make them, then it can't supply them into the blood. And that's the problem you see with leukemia, where you start seeing fewer red blood cells in the blood, that's those guys, and fewer platelets, and fewer white blood cells in the blood. And then eventually, when the leukemia cells run out of space to grow inside the bone marrow, they leak into the blood. So you start to see leukemia cells in the blood. Kind of like that. And actually, this picture right here explains almost all of the symptoms that you see in leukemia. So let's make some room to talk about the symptoms of leukemia. Symptoms. Okay, so firstly we said we see a decrease in the number of red blood cells, right? Which I'm just going to abbreviate as RBCs for red blood cells. And since red blood cells carry oxygen, this leads to symptoms like weakness and tiredness and fatigue. And the fatigue is from the brain not getting enough oxygen. And the body compensates for this by starting to breathe more quickly. So the patient starts to experience some shortness of breath. And because red blood cells give the blood its red color, the patient starts looking paler when they have fewer red blood cells. We also said that we see a decrease in the number of platelets in leukemia. So if the patient starts bleeding for whatever reason, they don't have enough platelets around to form that blood clot that stops the bleeding. So they experience prolonged bleeding. And they also see bruising, easy bruising. Okay? And finally, we said that there is fewer white blood cells, which I'm just going to abbreviate as WBCs. Right? And since white blood cells help fight off infection, this leads to more frequent infections, increased number of infections, or increased susceptibility to infections. And these cells, these leukemia cells that are really rapidly dividing, take up a lot of the body's energy. And because of that, you see symptoms such as weakness and symptoms such as weight loss, significant weight loss, which are things that you see in lots of other cancers because you also have rapidly dividing cells in other cancers. And then finally, the leukemia cells start to grow into the wall of the bone. And if you've ever had a bone fracture or a bone infection, you know that the wall of the bone has lots of very sensitive sensory nerves in it. And because of that, the patients with leukemia start experiencing bone pain. And that's not pain in just one bone, it's pain throughout the bones of the body. So it's more generalized bone pain. So if a patient starts showing signs and symptoms of leukemia, a doctor will often start off by getting a blood test. And if they get a blood test, the first thing that you'll see is this picture over here. You'll see fewer of the healthy normal cells, and you may even see the leukemia cells in the blood, right? So that would lead to the suspicion that maybe the patient has leukemia. And that suspicion can be confirmed by actually looking inside the bone marrow. And so that's this, I'm just drawing in the cavity inside the bone. And you can look inside the bone marrow by actually sticking a long needle inside the bone and drawing out some fluid and then looking at that stuff under the microscope. And that's actually called a bone marrow aspiration. So in a nutshell, this is what leukemia is all about.
I really truly wish I could have drawn all that up here for you guys, but I'm no artist. But I love this video because it shows us how knowing, you can say, I don't need to know the pathophysiology of this, right? I don't need to know this, just tell me what I need to care for, what I need to look for. But if you can understand the pathophysiology and you're taking an exam and a patient has leukemia, they may have one of these symptoms or side effects, or they may mention, one of the lab results you got or something like that, you can know why and know potentially how to treat that or what we're gonna do to treat that, or to be able to anticipate the treatment that's going to be ordered for these patients. Does that make sense? I am really big on knowing the why, and it's very easy to say, just tell me what I have to do, but you've gotta critically think, and that's what I mean by critically think, is if we can know these processes, what's actually happening physiologically, we can think through processes, and it'll give us more answers to the test, if you will, because we can think through them ourselves, right? We didn't just memorize a bunch of signs and symptoms, but we know why they have these signs and symptoms. Does that make sense? Okay. I do love this video, and I apologize for making you sit through watching videos in class, but leukemia was a hard one for me to grasp because it's not a solid tumor, and I feel like they made that make a whole lot of sense. This is the pathophysiology in a chart form for you. This is from your book, page 747 in your book. If you guys want to take a look at that, what's happening, we have this proliferation of these immature blood cells, and then what's going to happen, the most common signs that it's going to metastasize, or sites it's going to metastasize to, the central nervous system and the testicles, and then also we'll have lymph node involvement, liver, spleen, joints, all of that. But really what's happening is these leukemic cells are taking the place of our erythrocytes, our lymphocytes, our platelets, and then our body's not able to carry out the functions it needs to carry out. So risk factors, there's some genetic factors. Certain people with certain congenital or inherited abnormalities, Down syndrome is one of those that leaves them at higher risk for leukemia. Chronic lymphocytic anemia, you don't need to notice, it does have a familial trend to it, but that's not necessary for you guys to know. Chemical agents, benzene. So benzene was a solvent used in cleaning products, also in plastics. Patients that have been exposed to that higher risk for leukemia, as well as we talked about chemotherapeutics. We know that potentially we're going to have a high risk of causing some issues in the future, like leukemia. The alkylating agents are one of those, but we have to weigh the risks and benefits, right? Take care of what's happening now, and then we can look further down the road and be testing and screening and hopefully catch that earlier. But that is a risk. Different viruses, radiation exposure, immune deficiencies leave us at risk for leukemia. So we're going to talk about the way they're classified. We've got acute versus chronic leukemias, and the acute versus chronic, that is how the age of the damaged DNA that are proliferating out of control, the age of those is what defines it as acute versus chronic, okay? And then we talk about, there's myelogenous or lymphocytic. That's the type of white blood cell that's affected, so either the lymphocyte or the myeloblast. But we're going to talk about these four major types, okay? So when we're talking acute, think this is an immature hematopoietic cell and that is proliferating out of control. And we have ALL, which is acute lymphocytic leukemia, and that is the one that's most common in children. Okay? 90% cure rate in children, according to our book. Now, if an adult has ALL, the cure rate is less than 50%. Okay? So highly curable in children. Signs of this are going to appear really abruptly, very suddenly. They can be insidious, but typically those symptoms are going to appear abruptly. And then AML, acute myelogenous leukemia, is the most serious, and it makes up about 80% of adult leukemias. So the onset of this is very dramatic, very abrupt. They may start having like really serious infections, abnormal bleeding right from the onset, and these patients have a very poor prognosis. And then moving over to the chronic leukemias, these are going to be more prevalent in the adult population. CLL, this chronic lymphocytic leukemia, we're going to see that more in the elderly populations. And there's a strong genetic link to that one. And then CML, chronic myelogenous leukemia, it's linked to the Philadelphia chromosome. Okay, So if you see anything about the Philadelphia chromosome, chromosome is going to be associated with CML. In your book, page 636 in Lewis, there's a really good table that compares the two of these if you want to look at those. And sometimes they can't determine a specific subtype of leukemia. They may have both lymphoid and myeloid characteristics, and those patients really do not respond well to treatment. Very, very poor prognosis, excuse me. So, how do we diagnose this? We're gonna do some blood tests. These patients, what's a normal white cell count? I got like, you guys say 5 to 11, I've got 4,000 to 11,000. These patients' white cell counts are gonna be like 76,000 to 400,000, very, very high. So really high white cell count. But the differential, what might the differential show about these particular white cells? They're very immature, right? They're not gonna be able to serve their purpose. So they're gonna be very immature. And when all these immature cells are taking up the space of what could be healthy immune cells, then we have a problem. You can do a bone marrow biopsy. We're gonna take those cells, put them on a slide, look and see what we're looking at. They do this under conscious sedation, and they literally bore into the bone and pull out a chunk of that bone in the bone marrow and take a look at that. This video, I'll let you guys access it on your own. It's from MD Anderson. It's the patient's video for them, patients who are undergoing bone marrow biopsy, kind of what they're expecting. Yes?
Can you repeat the range for the white blood cells again?
The normal one?
Yeah.
4,000 to 11,000. But these patients will be like 76, it'll be wildly high.
Okay.
76,000, 400,000, wildly high. They may do like a lumbar puncture. They do a PET scan or CT scan to see if there's leukemic cells outside of the blood and the bone marrow. So our initial goal with these patients is remission. Okay, they're gonna come in and they're going to receive a combination chemotherapy, lots of steroids, biologic and targeted medications. We are hitting them really, really, really hard up front. We're wiping out their immune system, that's the goal, because that's the issue, right? Their immune system, wiping it out. These patients are gonna get really, really, really sick. Okay, we can use all of these different therapies to do that. And remember, when we're wiping out our immune system, these patients might be on neutropenic, or probably they're going to be on neutropenic precautions, right? And then we're going to do a hematopoietic stem cell transplant or a bone marrow transplant after we wipe that all out. Okay, these are the neutropenic precautions we talked about, we've been talking about, neutropenic precautions. These are the ones I want you to focus on. Don't use any outside sources, don't use your clinical site, don't use where you work. As your standard, use this, okay? So when you're taking an exam in our course, use this. This is from your textbook, okay? Only use your textbook as your resources, because it can vary from hospital to hospital a little bit, okay? So these patients are gonna be in a private room. Good hand washing, I talked about that. When we go in, we are doing really, really good hand washing. We have signage telling our visitors hand washing. No fresh flowers, no fresh plants for these patients. We're worried about any organisms that might be living in the soil, on the flowers, on the plants. If we don't have enough neutrophils, that can cause an opportunistic infection for these patients. No salads, no grapes. Limit the dairy. Why would we limit dairy? Bacteria, right? And we all know that some dairy has good bacteria, but this good bacteria that typically would be healthy for me or for you, somebody who is immunocompromised could make them very, very, very sick. Okay? If it cannot be washed and it cannot be peeled, they cannot have it. Okay? It must be able to be washed or peeled. At Children's Hospital, there's like a bottle of water that's open. There's like a timer on it. and once if they haven't finished it after a certain amount of time, last I heard 30 minutes, then they'll throw the bottle away, because we're worried about microbes. Okay, that's how serious it is. No stuffed animals. I have heard that they will allow stuffed animals, so like if children, if the parent washes it and brings it in a bag, like in a sealed, like in a trash bag or whatever, to keep it away from bacteria and things, and then they'll let them have that. But like if an adult, usually they're not gonna be, that's a fomite, carries around bacteria, it's not gonna allow them to have that. But there are certain circumstances with little ones that they do allow it. Air filtration, so these patients are gonna be in a positive pressure room, or they're gonna have HEPA filtration. So when I say positive pressure room, that means that the pressure in the room is greater than that outside of the room. So there's positive air being flown in. So anytime the door opens, that air is going to rush out of the room instead of air rushing into the room. Does that make sense? That way, no bacteria, none of the yucky air can come in, doors open, and air will rush out. So refer to this as your neutropenic precautions. Any questions on that? Okay. So I said that the goal for these patients is going to be a stem cell transplant. Okay, so they come in maybe 14 days, a couple weeks before they're going to have their stem cell transplant, and we're wiping out their immune system, right? Like I said, we could use chemotherapy, radiation, all the things to wipe out their immune system, because we're wanting to get rid of all of those leukemic cells that might be there. And these patients are going to get so sick. So sick. Because we are wiping everything out, right? Think about chemo and radiation, the effects that'll have on the patient, and then we are just completely wiping them out. They are going to look like, feel like they are on death's door. They're going to get really sick, okay? Then, we're going to replace all those hematopoietic cells that we wiped out with those of a matched sibling, or a half-matched relative, or a volunteer donor, or like a twin, like an identical twin, we do that. This is MNDP, stands for National Marrow Donor Program, formerly known as Be the Match. Have you guys heard of Be the Match? My goal is one day for them to call me up. I'm about to age out. I think it's 40. They may have extended it a little bit. But I've got 4 more years that they can call me. But basically, they'll send you an envelope, you swab your cheek, you send it in, and then you are part of this registry. And if a patient needs a bone marrow match, they can go to this registry, and if you are one, they'll call you and say, hey, you want to do this? You don't have to do it just because you signed up. And typically, I think it says 90% of the time, it's like giving blood, like you just give your blood. And so, I want them to call me so bad, I think it's so cool. But I just, so you just go, you sign up, they send you the stuff, you send it back in, and then you're on this registry to help somebody. So you can click, I think that's a clickable link if you want to click it and get on that list. This NMDP, you should be able to click it, and it should link you to their website. But if you guys have heard of Be the Match, I don't know why they moved to NMDP. It's very hard to remember to say. But you don't have to, but if you want to sign up for that, it's pretty awesome. Let's see. Okay, so now we'll talk about graft failure. So when they're giving these hematopoietic cells, sometimes they'll radiate them before they give them to the patient, just to help make sure that it will take. That's one thing that they do to try to avoid what's called graft versus host disease. That's when the graft is going to fail. We give like anti-rejection medications to help prevent this. So this is a video or a photo from the National Cancer Institute. So graft versus host disease. What it is the T cells of the donated marrow, graft, so the donated marrow, recognizes the person who's receiving that as foreign. Okay? So the graft recognizes the host as foreign, and the graft has all of the immune cells, right? So it begins to attack certain organs of the host. So skin, liver, and GI tract are the most common. And this response could happen 7 to 30 days after transplantation. So they will prophylactically give the patient corticosteroids, immunosuppressants. But once graft versus host disease disease is established, there's really no adequate treatment plan they necessarily will follow, but the patient will continue on their steroids and their immunosuppressants. And like I said, sometimes they're gonna irradiate the blood products before they give them to it to help prevent this, but that doesn't always, it's not just like the fix-all. Okay? So this is graft versus host disease. This is a skin reaction that you might see. Any questions? Okay. Moving on to lymphoma. So, the malignancy in the bone marrow and lymphatic structures resulting in proliferation of lymphocytes. So lymphocytes are a type of white blood cell. So lymphomas are cancers of the lymphocytes and the lymph nodes, and lymph nodes produce antibodies to fight infection. Okay, so two different types we'll talk about: Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma has a higher cure rate, and the way that I remember which one is the one with a more poor prognosis is I say I do not want non-Hodgkin's. That's how I remember which one is the worst one to get. I do not want non-Hodgkin's. Okay. So in Hodgkin's lymphoma, what's lymphadenopathy? Anybody know? Swelling of the lymph nodes, right? You can actually palpate those. Usually it's going to start, typically, in the cervical nodes. But that would be painless. These patients have weight loss, be tired all the time, fevers and night sweats, chills, common with these patients. Non-Hodgkin's lymphoma, they can have lymphadenopathy. It can be painless or painful, either way, and they have some very non-specific symptoms. When we are staging lymphomas, it's not our typical TNM staging that we talked about. Even though this is a solid cancer, the way we stage is based upon the number of regions involved, okay, in the lymph system, and whether or not it passes the diaphragm or crosses the diaphragm. So usually it'll start in the cervical nodes and it will work its way down, metastasize down, but it can start lower and metastasize up. But typically it's going to start in the cervical nodes and metastasize down. Okay, if it's on both sides of the diaphragm, where it's going to be stage 3 or stage 4. Once it crosses the diaphragm, then we stage up to 3 or 4. Okay, so stage 1, it's just that involvement of a single lymph node. You guys can see that in this first picture here. Okay. Stage 2, 2 or more lymph nodes are involved on one side of the diaphragm. And then stage 3, lymph node involvement above and below the diaphragm. And then stage 4 is involvement outside the diaphragm, so maybe liver, bone marrow. Okay, and then when they stage it, they'll either follow it by the letter A or B. And A is absence and B is presence of significant systemic symptoms. So those fever, night sweats, weight loss. So A means they don't have absence symptoms, and B means that we have symptoms. Okay, and again, you guys are not going to need to stage this. It's just important to know how this cancer works. Okay, so Hodgkin's lymphoma. This one has a better prognosis, right? If you hear of Reed-Sternberg cells, it's referring to Hodgkin's lymphoma. These abnormal giant cells that are going to be in the lymph nodes are called Reed-Sternberg cells. Typically, we're going to see this at ages 15 to 30 and over 55 years old. And we have an unknown etiology, potentially a virus, genetic, occupational toxins can cause it. And really slow, gradual onset. This is one of the most treatable types of cancer, really good outlook, and we may treat this more like a chronic disease. This is the standard chemotherapy regimen, is ABVD. You guys might recognize, you don't need to memorize it, but you may recognize some of these drugs from our previous lecture. Okay, non-Hodgkin's lymphoma, so the one that we do not want to have. That's just a good way for you guys to remember it. Usually we'll see this in older adults. There's a genetic component to it. Infections and environmental factors could cause it. And this could be like a slow to really fast progression, but by the time these patients are diagnosed with non-Hodgkin's lymphoma, they have widely disseminated cancer. It is everywhere, typically. So poor prognosis for these patients. Okay, what can we do for these patients? So we may be doing chemotherapy, targeted therapies, radiation. We're gonna have to help with pain control, spinal cord compression because of those tumors. Tumor lysis syndrome, we talked about that. We're treating cancers, they lyse open, they cause all kinds of problems for us. And then pancytopenia, and we could do a stem cell transplant for these patients. What is pancytopenia? Decrease in all of those red blood cells, white blood cells, and platelets. Okay? Okay, you guys wanna take a break? Yeah. Okay, let's break. There is a nursing home we're gonna be testing at tomorrow, Wednesday. Or you could do whatever. You can print that out there, or just write, whatever. Yeah, that's fine, yeah. Okay, just go to where you had your OB sim and keep walking down the hall down the left. Okay. And if it's not unlocked, ask one of the other faculty that'll be around in their offices if they can unlock it for you.